The following podcast is part of a certified educational activity titled Lipid Management Beyond Statins, Early Screening, Prompt Intervention, and Timely Intensification with PCSK9-Targeted Therapies. Access the entire activity and complete the post-test at peerview.com/QMF860. Downloadable slides and practice aids are also available.
Hello, everyone. This is Dr. Bart Duell from Oregon Health and Science University in Portland, Oregon. Welcome to this program on the treatment and management of hyperlipidemia by targeting the PCSK9 pathway to lower lipid levels in our patients. Our goals for today are fourfold. We're going to augment your knowledge of screening and diagnostic guidelines for patients with hyperlipidemia. We want you to understand the mechanisms of action, administration, efficacy, and safety of agents targeting the PCSK9 pathway to lower lipid levels. The third goal is to equip you with the skills to identify appropriate patients who may benefit from PCSK9 targeting therapy. And fourth, the goal is to suggest ways to collaborate with colleagues across disciplines to improve patient education and outcomes. So this is divided into several modules, and Module 1 is devoted to the importance of early screening, prompt detection, and accurate diagnosis of hyperlipidemia. So there are some important principles for lipid lowering in primary care. And the starting point is to do the basics first. It's important to screen patients, identify those at risk, and then treat them and follow up to ensure that the treatment is working properly. The following steps we'll discuss in sequence include what to do if statin therapy is not enough, addressing non-adherence to lipid-lowering therapy, which unfortunately is very high, and then strategies for selecting additional lipid-lowering therapies. So we know that elevated LDL cholesterol increases the risk of incident cardiovascular events at any age. Age has a dominant effect to increase risk, but within each age group, from 20 to 49, 50 to 59, 60 to 69, etc., all the way up to the age of 100, the higher the LDL cholesterol concentration, the higher the risk of both myocardial infarction and total ASCVD events. Now, it's important to remember that risk calculators look typically at 10-year risk, and you need to think about lifetime risk, particularly in somebody who, let's say, is 25 years old with an LDL cholesterol concentration of 250 milligrams per deciliter. Their 10-year risk will be very low, less than a few percent, but their lifetime risk of ASCVD events may be greater than 80%. So the earlier we can identify these patients and initiate treatment is going to improve their long-term outcomes. And a delay in treatment actually increases long-term risk of ASCVD events. So there are favorable trends in age-adjusted cholesterol levels that have occurred in the U.S. over the last couple of decades, showing that in both men and women, total cholesterol levels have decreased, LDL cholesterol levels have decreased modestly, HDL cholesterol levels have actually increased slightly, and triglyceride levels have also decreased over this time period. So those are all positive. So there are a number of different risk factors for dyslipidemia and ASCVD risk. So familial hypercholesterolemia is a genetically determined cause of very high cholesterol, seen in about 1 in 250 people. Other health conditions, including type 2 diabetes, being overweight and obese, can contribute to dyslipidemia. Dietary habits high in saturated fat and trans fat can cause hypercholesterolemia, and diets high in simple carbohydrate or excess carbohydrate can contribute to hypertriglyceridemia. Being sedentary can cause all lipid parameters to be off. Smoking can reduce the HDL cholesterol level. And all of these factors interact then with family history, the age of the patient, and sex of the patient to modulate both the dyslipidemia that may occur as well as the ensuing cardiovascular risk. So how do we recognize individuals at very high risk? Well, one way this is classified in the AHA-ACC guidelines is to identify patients with greater than one major ASCVD event or somebody with one event and multiple high-risk conditions. And major ASCVD events include a recent acute coronary syndrome within the last year, history of myocardial infarction, history of ischemic stroke, and notably symptomatic peripheral arterial disease, PAD, such as a history of claudication with an ankle brachial index less than 0.85 or previous revascularization or amputation. And as a side note, I want to emphasize that PAD is actually a major risk factor for ASCVD events and cardiovascular death. High-risk conditions are multiple. They include age greater than 20 years with any of the following: LDL cholesterol greater than 190, a diagnosis of familial hypercholesterolemia, history of CABG, PCI, type 2 diabetes, hypertension, CKD with an EGFR 15 to 59, current smoker, LDL cholesterol greater than 100 milligrams per deciliter despite maximal statin therapy, history of heart failure, and an elevated coronary artery calcium score. I would like to note that patients with the genetic condition homozygous familial hypercholesterolemia can have acute MI at the age of 6 or even younger. And so this issue of age greater than 20 falls off the wayside for those particular patients, and they require aggressive treatment as soon as you diagnose them. So strategies have been recommended for risk stratification based on U.S. cholesterol guidelines and European dyslipidemia guidelines. And there are similarities and differences between them. So in terms of risk scoring, both use typically a 10-year risk of CVD event and the ACC-AHA guidelines. And then for ESC-EAS guidelines, it's the 10-year risk of fatal CVD. For high risk, LDL goals updated in 2022 are LDL cholesterol less than 70 milligrams per deciliter and non-HDL cholesterol less than 100 milligrams per deciliter with a greater than 50% reduction from baseline. The European counterpart to this is an LDL cholesterol goal less than 70, as well as a greater than 50% reduction from baseline. For very high risk, the goals are more strict with LDL cholesterol goals less than 55 and non-HDL cholesterol less than 85 milligrams per deciliter from the AHA-ACC guidelines, as well as greater than 50% reduction from baseline. And then simply an LDL goal less than 55 milligrams per deciliter with the same greater than 50% reduction from baseline in the European guidelines. It's notable that the Lipid Association of India in 2023 identified an extreme risk category for which an LDL cholesterol goal less than 30 milligrams is actually recommended for the very highest risk patients and is optional in other patients, particularly because South Asians, including Asian Indians, have much greater risk of cardiovascular events compared to the rest of the world. Now, there are other differences between the AHA-ACC cholesterol guidelines and recommendations endorsed by the American Academy of Family Practice that are worth noting. So, as far as screening is concerned, the AHA-ACC says that it's reasonable to perform universal screening at the ages of 9 to 11, 17 to 21 years, and after age 21, every 4 to 6 years, and that the selective screening in children can be done between the ages of 2 to 21 years. The AAFP suggests that the current evidence is insufficient to assess the balance of risks and harm from screening, and so there's not a formal recommendation there. AHA-ACC recommends identifying risk-enhancing factors and use of the coronary artery calcium score. Similar to screening recommendations, AAFP has suggested that the evidence is insufficient to assess the benefit of coronary artery calcium score imaging. And then LDL cholesterol-lowering medications for primary prevention in adults up to 75 from the AHA-ACC recommends moderate intensity statin in intermediate risk patients. In high-risk groups should receive high high-intensity statin with the addition of ezetimibe or bile acid sequestrants as add-on therapy if needed in higher-risk patients. AAFP, on the other hand, recommends low to moderate intensity statin when ASCVD risk is greater than 10%. And then the final category of comparison is for LDL cholesterol lowering medication in patients over the age of 75, and AHA-ACC recommends that it is reasonable to initiate moderate intensity statin therapy and to continue this therapy. AAFP suggests the evidence is insufficient to recommend this treatment in older patients. Now, it's not just the LDL goal or target that matters, it's the time of treatment as well, or duration of treatment. So the Cardia prospective observational study stratified patients by their baseline LDL cholesterol level, and then these patients were followed for 20 years, age 40 to 60, and what was shown quite clearly is the patients who had the lowest quartile of LDL cholesterol had a cardiovascular event rate that was only 2.6%. This is with LDL cholesterol levels less than 96 milligrams per deciliter. And in the highest quartile with LDL cholesterol levels greater than 130.7 milligrams per deciliter, event rate was 8.6%. So 2.6 versus 8.6 over 20 years is a very dramatic, almost a one-third reduction in cardiovascular event rate. Do we really need to pursue aggressive LDL targets or goals? Well, we know that the goal of therapy is to not just lower the LDL cholesterol level, it's to stop progression of accumulation of atherosclerotic plaque and also to stabilize plaque to prevent MACE. In the general population with cardiovascular disease, an LDL cholesterol level of about 77 milligrams per deciliter will stop plaque progression in about half the population. So therefore, half the population needs LDL cholesterol levels lower than this to stop plaque progression. And moreover, setting a limit or goal of less than 55 milligrams per deciliter is even better for stabilizing plaque and reducing high-risk plaque so that it can not cause an ACS. And then in some patients, a limit less than 30 may be even better. And it is important to recognize that the risk of ASCVD events is proportional to the LDL cholesterol concentration all the way down to 10 to 20 milligrams per deciliter. So it's important to recognize there is no threshold below which the risk of cardiac events is eliminated. So why would anyone set an LDL cholesterol goal less than 30 milligrams per deciliter? Well, there are a variety of types of evidence available to support this approach, but one in particular that I'd like to highlight is a post hoc analysis from the Fourier trial. And in this trial, it's a post hoc subgroup analysis. The primary trial, of course, showed that dramatic LDL cholesterol lowering reduced the risk of cardiac events. But in a subgroup of patients, specifically 2,034 high-risk statin-treated patients with stable CVD with baseline LDL cholesterol level less than 70 milligrams per deciliter in this trial were analyzed. So this is not the broader population. It's a subgroup, and this means that in the placebo group, the median LDL cholesterol concentration was 66 milligrams per deciliter. And historically, many guidelines suggested that in a high-risk patient with stable CVD, an LDL cholesterol level less than 70 milligrams per deciliter was adequate. But in this analysis, those who got evolocumab had a mean or median LDL cholesterol concentration of 21 milligrams per deciliter. So 66 in the placebo group, which by historical guidelines was adequate, versus 21 milligrams per deciliter with evolocumab. And lo and behold, this showed that the risk of ASCVD events, specifically cardiovascular death, myocardial infarction, or stroke, all in patients with baseline LDL cholesterol levels at entry less than 70, showed a hazard ratio of 0.7, so 30% reduction in risk of cardiovascular events over 30 months of treatment. And those two outcomes curves diverged after about 12 months. So within 1 year, there was evidence of this cardiovascular benefit. So what do you do if statins aren't enough? There are many patients on statin therapy who are not at goal, and LDL cholesterol goals have become more aggressive, so this needs to be addressed. And unfortunately, we know that even with patients with cardiovascular disease, statin use is low. And there are data showing that patients with LDL cholesterol levels greater than 100 milligrams per deciliter, overall, only a small percentage are actually treated appropriately. About 29%, about 36% are on low intensity statin therapy that is lower than what's recommended. And then 75% are not on statin therapy. That's overall. Now, looking at the group with secondary prevention, the very highest group, even in that group, 70% are not on a statin, and only 21% are considered to be treated appropriately. So lots of factors contribute to this. It's not all that healthcare providers have the responsibility. Patients have a role in this as well. But the data are similar looking at different health groups as well. So Asians, Blacks, Hispanic, whites, the rates are very high, and nearly 75% of individuals with elevated 10-year risk of ASCVD are not currently using statin therapy. So this is a failure on the part of the healthcare system. So why does this happen? Well, first of all, sometimes patients are actually taking a maximal dose statin, and it's just not enough to achieve the necessary LDL cholesterol goals. In addition, intolerance or adherence for other reasons may necessitate the use of alternative therapies. And that can include ezetimibe and other agents, but among the most potent agents we have are the PCSK9 targeting therapies. So one purpose of this presentation is to discuss who might benefit from these therapies after you've done all the other basics. So although PCSK9 targeting therapies are available, they continue to be underutilized, and the route of administration, i.e. subcutaneous injection, may not align with patient preference, but it turns out that most patients, even with needle phobia, do very well with these therapies. So we'll move on to the second module, which is applying the latest evidence, the role of PCSK9 targeted therapies in addressing unmet treatment needs. So non-adherence to statin therapy is very high. More than 50% of high-risk patients are actually not using a statin after months, even after a cardiac event. And patients are not taught sometimes why they're taking lipid-lowering medications, or they are taught, but they don't remember. So there are factors both in the patient and in the prescriber that are contributors to poor adherence, and it's helpful to go through these just to think about ones that might be correctable or modifiable. So healthcare providers often are very busy. They may have trouble identifying or risk stratifying patients who may need more intensive therapy. There may be uncertainty about benefit in certain patient groups. There are some discrepancies among different guidelines, as I highlighted. Sometimes there's clinical inertia, particularly if the time with the patient is very limited. There's diffused responsibility for prescribing. For example, the primary care provider may expect the cardiologist to do it, and the cardiologist may expect the primary care provider to take on that responsibility. Time limitations certainly contribute. And then among pediatric cardiologists and others, there's often a lack of formal training on cholesterol disorders. On the patient side, patients sometimes get apathetic. They don't take the medications as prescribed. They may be skeptical about treatment goals or the need for treatment. They may worry about safety. They may think they're not at risk, cardiovascular risk, when they are. They may actually be unaware of their cholesterol levels or goals and may not fully understand or be aware of why cholesterol medications were prescribed. And this, again, we as healthcare providers tell our patients these things, but sometimes they don't hear it or they don't remember it. So ensuring that this information is communicated is important. Now, statin intolerance is a very common issue, and the most common statin side effect is so-called SAMS, referring to statin-associated muscle symptoms. And I'll bring your attention to a guideline statement from the National Lipid Association, published in 2023, with Dr. Warden as the lead author. And this points out a number of things I'll briefly go over. And the first is that about 10% of patients in clinical practice experience symptoms of SAMS during statin therapy, but it turns out that only 1 to 2% have symptoms that are actually causally related to the statin. So 90% or so of patients with muscle aches during statin therapy have it as a coincidental finding rather than due to the statin. Nonetheless, even if it's not related to the statin, this interferes with the willingness of patients to continue therapy. So among the many strategies that you can implement to get through this, one is to use the same statin at a lower dose. Often it's more practical to just switch to a different statin at a low dose. You can add a non-statin to very low dose statin therapy, or even use non-statins without a statin. I encourage you to read the guidelines to go through this in more detail, but you can do more frequent or less frequent dosing 3 times a week, use other statins that maybe the patient hasn't tried before, and then consider using non-statin therapies that include PCSK9-Targeted Therapies, bempedoic acid, bile acid sequestrants, ezetimibe, and so on. So it is important to consider race and ethnicity when treating patients with ASCVD risk when statin therapy is being used. Higher doses of rosuvastatin are not recommended in Japanese, Chinese, Malay, and Asian Indians, typically because they may have higher rosuvastatin plasma levels due to diminished metabolism. So for rosuvastatin, starting doses of 5 milligrams a day are recommended in those who are of Asian descent. And caution is indicated as the dose is up titrated. And then among Blacks, there's no sensitivity to statin dosage, but baseline CK levels sometimes are higher in Black patients than in white patients. So that needs to be taken into account when using CK for monitoring possible muscle symptoms. So there are lots of barriers and facilitators of adherence to lipid-lowering therapy, and I've highlighted some of those already, but being sure to educate healthcare providers about healthcare disparities, socioeconomic status, sex, age, race, ethnicity. Improving access to healthcare monitoring helps. Having standardized metrics is very helpful. Pharmacy-based programs sometimes can be helpful both to avoid polypharmacy, but also ensure that patients are taking the medications as prescribed. This includes monitoring prescription refills, and then addressing the cost of healthcare is a barrier for many patients, and trying to make sure we prescribe therapy that's both affordable and maintainable for the patients is essential. And then fear of side effects is a big deal, and we cannot alleviate that with a single conversation. So keeping an open mind, listening carefully to the patient, and addressing those concerns as they come up is essential. So what about selecting additional lipid-lowering therapies? We have great tools that allow us to get excellent LDL and non-HDL cholesterol results, but it's necessary to step out of the box of statin therapy to use these. So statins absolutely are the foundation of lipid-lowering therapy. They're very effective and safe. Proven safety over more than 35 years of clinical use, and they're effective in primary prevention for prevention of MACE, effective in secondary prevention of MACE, and they have rapid time to benefit and generally very well tolerated. Now, the reduction in events typically with statins have been about a 28% reduction in MI, 20% reduction in stroke, and 17% reduction in cardiovascular death. But I want to bring your attention to the important point that those are all short-term studies, 3, 5, 6 years. And other data show that if you treat for 10 to 50 years, the benefit's even greater, possibly up to a 75 or 80% reduction after 52 years of treatment. So long-term treatment is an important goal here. Now, other non-statin therapies lower the LDL cholesterol level to a variable extent. The mean reported drop with bempedoic acid is 17%, although as monotherapy, it may drop LDL 25 or even up to 30%. Ezetimibe in the range of 20 to 25%. The PCSK9 targeting therapies are much more potent. Inclisiran reduces LDL cholesterol 50%, whereas alirocumab and evolocumab reduce the LDL cholesterol level by 50 to 60%. All of these I mentioned, bempedoic acid, ezetimibe, alirocumab, evolocumab, are proven to prevent cardiovascular risk. And inclisiran, on the other hand, is still involved in a cardiovascular outcome trial, so we don't have the proof yet. So combining these medications allows us a greater chance of achieving the necessary LDL cholesterol lowering. And a variety of studies have shown that if you don't get the LDL cholesterol goal you want, you add a second medication or a third medication or sometimes even more in the very high risk patient. And on this slide, it shows that the LDL cholesterol level started out at 200 milligrams per deciliter, dropped to about 100 milligrams per deciliter after statin therapy, down to 78 after adding ezetimibe, down to 62 after adding bempedoic acid, and then down to 31 milligrams per deciliter after adding a PCSK9 targeting medication. So this is clearly for a very high-risk patient, but the important point is in this particular patient, they needed 4 lipid-lowering therapies to reach this very important but very low LDL cholesterol goal. So how do these different drugs work? Ezetimibe works in the intestine to reduce cholesterol absorption and thereby reduce cholesterol content in the hepatocyte. Statins and bempedoic acid both temporarily inhibit cholesterol synthesis through different checkpoints and reduce cholesterol availability. All 3 of these then upregulate LDL receptor activity because of that reduction in hepatic cholesterol membrane content. The PCSK9 monoclonal antibodies sequester PCSK9 in plasma and prevent it from doing its terrible deed of destroying the LDL receptor. And inclisiran works differently by inhibiting PCSK9 messenger RNA, preventing translation and production of the PCSK9 protein, thereby accomplishing the same goal of preventing destruction of the LDL receptor by PCSK9. And normally, the LDL receptor recycles maybe 100 times. It binds an LDL particle, dumps it in the cell, and goes back out to the cell surface to capture more LDL. But in the presence of PCSK9, it's a one-way trip. The complex of PCSK9, LDL, and the LDL receptor goes to the lysosome and is destroyed. So PCSK9 targeting monoclonal antibodies do interfere with that process that I mentioned and allow the LDL receptor to recycle over and over again. As I said, perhaps up to 100 times. So these drugs, both alirocumab and evolocumab, reduce LDL cholesterol levels by 50 to 60%, as I indicated, and thereby dramatically reduce cardiovascular events. In the trial with alirocumab, it wasn't fully appreciated that it was safe to have LDL cholesterol levels very low. So treatment was back, which allowed LDL cholesterol levels to come up a bit, but there was a mean 61% reduction with alirocumab and a 59% reduction with evolocumab at 48 weeks, the other at 52 weeks. Now, a large proportion of patients don't stay on their PCSK9 inhibitor monoclonal antibody, i.e. evolocumab and alirocumab. The studies show that by 300 days, close to a year after initiation of treatment, only about 60% of patients are still on their therapy. So 40% stop treatment. And this is multifactorial. Some think they're done with treatment. Some don't like the cost. Some get tired of it. Some just forget. They become apathetic about it. So it means at the minimum, patients need reminders and encouragement to stay on therapy. Now, another alternative possibly is to give a drug like inclisiran, which long-term requires only 2 injections per year, as opposed to 26 injections per year for PCSK9 monoclonal antibodies. And so, in theory, if patients get the injections, that can improve adherence. Typically, the medicine is given in the doctor's office, so that means the patient has to come in, and you as the provider know whether they got the injection or not. It can be administered by your medical assistant or nurse or by you, but that way adherence hopefully will improve and allow more sustained LDL cholesterol lowering. How does the inclisiran, which is a small interfering RNA molecule, differ from PCSK9 monoclonal antibodies? Well, as I mentioned already, in the presence of PCSK9, the LDL receptor is destroyed, thereby allowing less LDL to be cleared from plasma. And interestingly, PCSK9 is produced whenever the hepatocyte makes LDL receptors. So very counterintuitive to make this precious LDL receptor and a saboteur to destroy the LDL receptor. But PCSK9 monoclonal antibodies sequester the PCSK9 in plasma and prevent it from interacting with the LDL receptor. Plasma levels of PCSK9 actually go up, but it's inactivated because it's all bound by the antibody. The PCSK9 targeting siRNA has a tag on it to make it specifically go to the liver, where it then inhibits translation of messenger RNA for PCSK9 and also contributes to the destruction of that mRNA through RNase H. And by doing that, it means PCSK9 levels are low and thereby unleashes the LDL receptor to do its job. Long-term treatment with inclisiran was demonstrated in the Orion 8 trial, and it showed the LDL cholesterol reduction was 49.4%, first documented at 90 days, although we know that the levels go down even after 30 days after the first injection. And the results were very consistent over 3 years of treatment. The second part of this analysis shows that among patients with ASCVD, the LDL cholesterol level decreased by 51%, and in those with an ASCVD risk equivalent, it went down 42.4%, but the results of other studies suggest that the LDL cholesterol lowering is typically comparable in these two groups. The long-term safety profile is very favorable, as well as a post hoc analysis of MACE to try to estimate cardiovascular benefit. And those analyses showed that it appears that inclisiran reduces risk of MACE, although we need the cardiovascular outcome trial to show that definitively. And then major severe treatment emergent adverse events based on injection site reactions were not seen. Moderate was seen in 0.8% and mild 5.1%. So in general, very well-tolerated medication. So the FDA-approved PCSK9 inhibitors include, as I've been talking about, inclisiran, the small interfering RNA, and monoclonal antibodies that include alirocumab and evolocumab. And I've discussed most aspects of the differences between these. I'll mention again that the MACE reduction is still pending to be shown with inclisiran. The administration is subcutaneous. As I mentioned, the inclisiran is given by a healthcare provider or staff in the clinic, and monoclonal antibodies are given at home. Both reduce Lp(a) modestly, 17 to 25% with inclisiran and 25 to 30% with alirocumab and evolocumab. So what about the safety data? Injection site reactions are the most notable issue. Other conditions can include nasopharyngitis, upper respiratory infection, influenza symptoms, back pain. With inclisiran, in addition, there can be arthralgia and bronchitis, but majority of patients do very well with these therapies, and discontinuation rates are very low. So there are a number of exciting new treatments that are in development for blocking PCSK9, and one is a subcutaneous injection similar to the monoclonal antibodies. Lib-003 is an adenectin adjunct molecule that lowers LDL cholesterol levels by more than 50%. There is an oral agent in development, MK-0616, that lowers LDL cholesterol levels by 60.9%. It's in phase 2 trials now, oral tablet once daily. Verve is a genetic treatment or modification company that's developed a technique to, in a human, give a therapy to basically break the gene for PCSK9. They use CRISPR-Cas9 to induce a mutation that causes a null effect and makes production of PCSK9 go away. This is in phase 1B therapy, so this is very, very early, but it lowers LDL cholesterol levels 60%, and it's an IV infusion that would be given once in a lifetime. And then there's a vaccine that targets PCSK9 and not as exciting as the others. It's a subcutaneous injection once a year that is in phase 1 therapy. So far, lowers LDL cholesterol levels by only 13%. So we're on to the last module, which is practical application of PCSK9 targeting therapies and how to optimize hyperlipidemia outcomes in a family practice setting. So we've discussed the stages of doing the basics first, moving on beyond statins if needed, addressing non-adherence, and then selecting additional lipid-lowering therapies as needed. So the goal here is to translate this knowledge into practice. So a simple guide for treatment intensification is, number one, optimize treatment with or without ezetimibe first. These drugs are generic, they're inexpensive, they're safe. They have proven efficacy for LDL cholesterol lowering and ASCVD prevention. So that is the first choice. And rosuvastatin 40 milligrams a day is the highest potency of statin available, which may lower LDL cholesterol levels by an average of 60%. And then with ezetimibe, on average, a 20 to 25% additional LDL drop. So adding on non-statin therapies may include bempedoic acid, the PCSK9 targeting therapies we've been talking about, possibly even bile acid sequestrants. And then if it becomes too complex, patients can be referred to a lipid specialist if the LDL cholesterol goals cannot be achieved. So who's most likely to benefit from a PCSK9 targeting therapy? The primary categories then are high-risk patients with ASCVD who are not at lipid goals, patients who are statin intolerant who are not at goal, and then patients with contraindications to statins, such as very rare allergy, for example. So I wanted to go through a couple of cases to highlight some of these points. So the first case is Shandani, a 41-year-old woman of European and South Asian descent. So her BMI is mildly elevated at 27 kilograms per meter squared. Her medical history is notable for a TIA 3 years ago, as well as hypertension. Her current blood pressure on treatment is 122/77. Her LDL cholesterol concentration is severely elevated to 200 milligrams per deciliter. Details about her family history are not available. It's unclear whether she has familial hypercholesterolemia or not. But her current medications include ezetimibe, 10 milligrams a day, icosapent ethyl, losartan hydrochlorothiazide combination at a dose of 100 milligrams / 25 milligrams a day, and then aspirin 81 milligrams per day. So she's on some medications, but there are lots of things not right. So the visit notes highlight that obviously this is a new patient visit. She's statin intolerant with aching pain and fatigue on rosuvastatin 40 milligrams in the past. And then the medical documents also show that the previous physician considered a gene panel for FH. So 2 questions. What is her risk level and what is her LDL cholesterol goal? So she's clearly at very high risk. Her high risk features include LDL cholesterol of 200 milligrams per deciliter on ezetimibe, which means her previous LDL cholesterol level was even higher, maybe 250 milligrams per deciliter or higher. She has treated hypertension, history of a TIA, she's overweight, and she has South Asian ancestry, which is a risk-enhancing factor. So the treatment strategy was to continue the ezetimibe and then give a trial of low-dose rosuvastatin 5 milligrams a day or atorvastatin 10 milligrams per day, and then reassess the lipid levels. If that's not enough, which is very likely to lower her LDL cholesterol, then add a PCSK9 targeting therapy if insufficient LDL lowering is achieved, and then consider a referral for genetic testing for FH, familial hypercholesterolemia. Now, ACC lipid goals would be an LDL cholesterol level at least less than 70 milligrams per deciliter with greater than 50% reduction from baseline. And then I mentioned strategies earlier for managing statin intolerance, and I'd refer you again to that document from the National Lipid Association. So the next case is Walter, a 74-year-old white man who's had type 2 diabetes for 10 years. He has complications of neuropathy. He's had a myocardial infarction. He had percutaneous intervention with a stent placed 3 years ago. He has heart failure class 3 by New York Heart Association criteria. CKD stage 3A2. His eGFR is 40 mils per minute, and he has hypertension. His hemoglobin A1C concentration is 7.1%. His blood pressure is very good, 118 over 71 millimeters of mercury. His LDL cholesterol concentration is too high. It's 150 milligrams per deciliter. His potassium level is 4.2 milliequivalents per liter. His current medications include maximal dose atorvastatin, 80 milligrams a day, ezetimibe, 10 milligrams a day, the combo metoprolol hydrochlorothiazide at 100 milligrams and 50 milligrams respectively, sacubitril and valsartan at 97 milligrams and 103 milligrams per day, finerenone, 10 milligrams a day, metformin ER, 1,500 milligrams a day, empagliflozin, SGLT2 inhibitor, 25 milligrams a day, clopidogrel, high dose, 300 milligrams a day, aspirin, 81 milligrams a day, and furosemide, 40 milligrams a day. So multiple medications. And he's here for a routine quarterly follow-up visit, mentions that he does not need any medication refills. He still has plenty left since his last visit, which is suspicious. So first of all, what is his risk level and what is his LDL cholesterol goal? Well, he's in the very highest risk category, and his LDL cholesterol goal by ACC/AHA guidelines is less than 55 milligrams per deciliter, with a non-HDL cholesterol goal less than 70 ideally, but at least less than 80 to 85 milligrams per deciliter. So what can be done for him? Well, he was changed from atorvastatin 80 milligrams a day to rosuvastatin 40 milligrams a day. He also was initiated on treatment with inclisiran, 284 milligrams a day. And he was also referred to the pharmacist for education. And one of the hopes was that greater compliance with his medication may allow him to achieve even better goals. And I point out again, the fact that he did not need medication refills doesn't prove he's non-compliant, but it suggests that it's more likely that perhaps he is not taking the medication as prescribed. And this combination lowered his LDL cholesterol level to 60 milligrams per deciliter. So reduced from 150 milligrams per deciliter to 60 milligrams per deciliter. Not quite to the LDL cholesterol goal of less than 55, but close. Okay, so we're getting close to the end. The 2018 AHA-ACC cholesterol guidelines emphasize the need for shared decision-making. And there's a checklist that you can look at for ASCVD risk assessment, look at lifestyle modifications, look at the potential net clinical benefit of pharmacotherapy, importantly, discuss cost considerations, and then at the end of the day, make a shared decision based on strategies moving forward. So an interdisciplinary approach is sometimes difficult to put in place, but certainly can improve adherence. And a team-based approach offers many benefits. Number one, it reinforces the message given to the patient, but it also helps ensure nothing falls through the cracks. So who can be on the team? Well, it varies from clinic to clinic, but this may include the primary care provider, cardiologist, endocrinologists, clinic nurses, clinical pharmacists, dietitians, and then other educators, particularly diabetes educators for those with diabetes and heart failure, their training as well. And what this may do is improve diagnosis. It can refine individualized treatment plans according to cardiovascular risk profile, comorbidities, and so on. And then the ultimate goal is to improve adherence to both lifestyle modification and pharmacotherapy and ensure that patients reach the necessary goals for cardiovascular prevention that include lipid levels as well as blood pressure, trying to achieve optimal body weight, and diabetes control as well. So medication access starts with appropriate patient selection. Indications for PCSK9 targeting agents and bempedoic acid currently are for FH and or ASCVD. Patients without either of these will easily be denied by insurance plans, not always, but commonly. And then background therapy is key. Patients need to be on statin therapy. It could be a dose of 0, but they need to have at least tried statin therapy. And then you need to carefully document, why do you need to use this medication? What's the indication? What degree of LDL cholesterol lowering is needed? Think about the side effect profile and document in your clinic note, specifically explain to the insurance plan why this drug needs to be approved. And then don't be afraid to appeal. Something like half of denials are dropped. Drug request denials are dropped. And on appeal, though, a large number of those can ultimately be approved. So the key takeaways from our program today are that hyperlipidemia is a very common problem, but it's also commonly underdiagnosed and undertreated. The second point is that LDL cholesterol as well as non-HDL cholesterol goals have become more stringent as we've learned more about the benefits of cholesterol lowering and the risks of hypercholesterolemia in causing ASCVD. The third point is that PCSK9 inhibitors are currently the most effective second-line lipid-lowering treatments, but adherence to the monoclonal antibodies and getting patients covered has been challenging. Fourth, patients at very high risk are the so-called low-hanging fruit for intensification of lipid control and are among the first candidates for adding more intensive non-statin therapy. And that in patients with very high LDL and those who are at high and very high risk, combination lipid therapies are typically required. And the final point is that use of statin and non-statin therapies is suboptimal and needs to increase at this point, with the long-term goal, of course, is of achieving better LDL cholesterol and non-HDL cholesterol lowering and prevention of ASCVD events. So this ends our discussion for today. I hope you found the activity informative and useful for your practice. Please don't forget to download the practice aids and slides for this activity by clicking on the appropriate icons in the menu, and appreciate you joining. Thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation. To access all materials for this activity, visit peerview.com/QMF860.